Okay, so let's talk about or discuss about calcium. Calcium, it is uh, decrease in ionized calcium concentrations in blood can cause neuromuscular irritability, which may become clinically apparent as irregular muscle spasms called as tetany. Okay, so regarding calcium, it's an electrolyte that is important in neuromuscular excitability. Okay, so that's one of the functions of calcium. So for the functions of calcium, first you have blood coagulation. So without calcium, blood will not clot. Okay, so that's the target. Calcium is the target uh, of EDTA or EDTA. So if you're using EDTA or EDTA, the reason why the blood sample will not clot, it's because of uh, the ability of EDTA to chelate calcium. Okay. Next, enzyme activity. So it's also important in the activation of uh, the, the activation of some enzymes. So without calcium, there are enzymes that are not functional or not active. Next, excitability of skeletal and cardiac muscle. And it's also important in the maintenance of blood pressure. So for the regulation of calcium, there are three main hormones that are important in the regulation of calcium. Okay. So first hormone, it's the parathyroid hormone. So it's secreted by the parathyroid gland. And the function of PTH is to increase, okay, the rate, or it activates bone resorption. So what is bone resorption? So it's the transfer of calcium from bone, which is the normal location of calcium. So this is the bone. So it's the transfer of calcium from bone to blood. Okay, so bone to blood. So that's bone resorption. So the purpose of bone resorption is to increase calcium level in blood or in your plasma. Okay. So PTH secretion into blood is stimulated by a decrease in ionized calcium. So meaning the stimulus for PTH production, it's the decrease in ionized calcium in blood. Okay, so if there's a decrease in ionized calcium, automatic, that's the stimulus for your parathyroid hormone, parathyroid gland to produce more parathyroid hormone. Okay. Now, the PTH secretion is stopped by an increase in ionized calcium. Now, if the concentration of calcium reaches na sa normal concentration, then the body will, or the parathyroid gland will stop its production of PTH. Okay, so that's for PTH. Okay, so if there's a decrease in ionized calcium in blood, that is the stimulus for the production of parathyroid hormone. Okay, there's an increase, okay, or the level of calcium is within the reference range, that's a signal for your body to stop producing PTH or to slow down the secretion of PTH. Next, PTH conserves calcium. This is by increasing tubular reabsorption of calcium ion. So it promotes the reabsorption of calcium, okay, PTH. And it also stimulates the renal production of active vitamin D, okay, active form of vitamin D. Next, you have vitamin D. So vitamin D, or cholecalciferol, the active form of vitamin D increases calcium absorption in the intestine. Okay, so for PTH is more of reabsorption, and vitamin D is for the absorption of calcium. And vitamin D also enhances the effect of PTH on bone resorption. Okay, so PTH, the effect, you have increase in calcium. Same with vitamin D. Okay, increase in calcium. Okay. Next, you have calcitonin. So calcitonin is a hypocalcemic hormone because the primary function of calcitonin is to decrease the concentration of calcium. So it is secreted in response to hypercalcemic state. So if there is excessive amount of calcium, your body will produce more calcitonin to normalize the calcium concentration in your blood. Okay? So it is secreted when the concentration of calcium in blood increases. And the function or the action of calcitonin is to inhibit both PTH and vitamin D. So it inhibits the reabsorption and absorption of calcium. Okay, so that's for calcitonin. Okay, next, the distribution of vitamin D. So 99, no, not vitamin D, this is calcium. Okay, distribution of calcium. So 99% of calcium in the body is part of the bone. Then 1% is mostly in blood and other ECF. So it's uh, predominant, no, majority of calcium is present in bone. Okay, only 1% is present in blood and other extracellular fluid. So for the 1%, 45% of that is free calcium or the ionized form. 40% is bound to proteins and 15% is bound to anions. Okay, approximately. Okay, so 40, 45, this is 85, 15% bound to anions. So approximately 45% ionized, 40% bound to proteins, and 15% bound to anions. Okay, so for hypocalcemia, hypocalcemia is the decrease in calcium concentration in blood. So what are the causes of hypocalcemia? So first is primary hypoparathyroidism. So for primary hypoparathyroidism, there is a decrease in the production of PTH by the parathyroid gland. So it's decreased. So remember that PTH is for the reabsorption of calcium. So meaning, if there is decrease in PTH, there's also decreased reabsorption of calcium in the kidneys. Okay? So meaning, for primary hypoparathyroidism, kidney increases excretion of calcium. So meaning there is an increase in the excretion of calcium due to the decrease in PTH. And PTH also promotes the absorption of vitamin D. So another effect of primary hypoparathyroidism is the decrease in vitamin D because PTH promotes the absorption of vitamin D. Okay. Next, hypomagnesemia. So for hypomagnesemia or decrease in magnesium concentration, it inhibits the secretion of PTH. Okay. And it also impairs the PTH action at its receptor site. And it causes vitamin D resistance. Okay, so those are the effects of hypomagnesemia. So if it inhibits the secretion of PTH, meaning there's a decrease in PTH level. So decreased PTH level, there's also decreased absorption, reabsorption of calcium sa kidneys. So the effect, you have decrease in calcium. Okay, another, it impairs PTH action at its receptor site, meaning it can cause resistance, okay, of the cells to PTH, okay, or the receptor to the PTH. So no reaction between the receptor and the PTH, meaning there's no reabsorption of calcium. Another, it causes vitamin D resistance, meaning the receptor of vitamin D is resistant to vitamin D. So meaning there's no it will lead to decreased absorption of calcium in the intestine. So the effect, you have decrease in calcium. Okay. Another Another cause of decrease in calcium is pancreatitis because of increased intestinal binding of calcium. So there is decreased absorption of calcium, okay, for pancreatitis. And for vitamin D deficiency, it lead to increased PTH production or secondary hyperparathyroidism. So for vitamin D deficiency, remember that vitamin D is important, or the second hormone that is important in increasing calcium concentration. So if there's a problem with vitamin D, the response of your body is to increase the PTH production. Okay, so there is an increase in PTH due to the decrease in vitamin D, and this is what we call secondary hyperparathyroidism. So there's no problem with the parathyroid gland. The problem is in the levels of vitamin D. There's a problem with vitamin D concentration. So the response of your body is to increase the production of PTH to compensate the decrease in calcium concentration. Okay. Next, renal disease. So for renal disease, there is altered vitamin D production because vitamin D is the active form of vitamin D is produced in the kidneys. So we have decreased vitamin D, active form of vitamin D. Thus, it will result to decrease in calcium concentration in blood. Okay, so there's decrease in the absorption of calcium. Okay, because of renal disease. Next is rhabdomyolysis. So for rhabdomyolysis, you have the release of phosphate from uh, damaged muscle cells. Okay, and that phosphate will bind with calcium. Okay, and remember that in the three forms of calcium, the sensitive marker of hypo and hypercalcemia, it's the ionized one. Okay, ionized calcium, not the calcium that is bound to, okay, phosphate. Okay, next, pseudo-hypoparathyroidism. So for pseudo-hypoparathyroidism, um, there is enough PTH produced by the body, but the response, okay, the target tissue is not that responsive to PTH, meaning it's resistant to PTH. So PTH target tissue response is decreased. So this one is for pseudo-hypoparathyroidism. So your body is producing enough PTH, but the problem is the target cell of PTH is not that responsive. So if there's no reaction between PTH and receptor, no bone resorption and no reabsorption of calcium. Okay, so that's for um, what do you call this? Uh, um, Pseudo-hypoparathyroidism. Next, you have surgery and intensive care. So in surgery and intensive care, the maintenance of a normal ionized calcium concentration in blood is beneficial to patients in either surgery or intensive care because regarding calcium, it's important for blood coagulation and also for the maintenance of blood pressure. Okay. Now, what are the symptoms of hypocalcemia? So first is neuromuscular irritability and cardiac irregularities. Okay. Then next is you have uh, parasithesia. Okay. Or burning or prickling sensation that is usually felt in the hands, arms, legs, or feet, and it's because of the decrease in calcium concentration, muscle cramps, tetany, and seizures. And it can also cause arrhythmia, okay, or heart block. For heart block is when electrical signal that control your heartbeat is partially or completely blocked, okay. So if there is hypocalcemia, usually the symptoms, it's related to muscles and nerves. Okay, so that's for hypocalcemia. Next, regarding treatment, oral or parenteral calcium therapy, and another is vitamin D is sometimes administered, and last you have magnesium therapy because hypomagnesemia is one of the causes of hypocalcemia. Okay? Kaya diba, hypomagnesemia will result to decreased production of PTH. Okay? So to eliminate that cause, okay, you can administer magnesium, okay, as replacement. Okay, so these are the common approach in dealing with hypocalcemia. Okay, so next is hypercalcemia. So hypercalcemia is the increase in calcium concentration. So the first cause of hypercalcemia is primary hyperparathyroidism, meaning there's excessive production of PTH by the parathyroid gland. Maybe there's a tumor, and that's the reason why there's excessive production of PTH. Okay, so primary hyperparathyroidism is the main cause of hypercalcemia. Okay, So for this one, there's excess secretion of PTH. So increased PTH, you have increased bone resorption and increased okay, sorption of calcium. Okay, so the effect of excessive production of PTH is abnormally high calcium concentration in blood. Okay. Next, various type of malignancy. That's the second leading cause of hypercalcemia. It's because increase in calcium is the sole biochemical marker or the hallmark of malignancy. So if the patient has cancer, it is expected that the calcium concentration of that particular patient is elevated. Now, why man elevated? It's because of the release in PTHRP. So what is PTHRP? It's parathyroid hormone related peptide. Okay, so PTHRP is identical to PTH and it also causes bone resorption. So people with cancer, they have high rate of bone resorption. So meaning more calcium is transferred from bone to blood. Okay. So that's the second cause, the second leading cause of hypercalcemia. Okay, malignancy or cancer. Okay, so continue ta. So next you have hyperthyroidism. So it can cause hyperparathyroidism, and if there's hyperparathyroidism, you have increase in PTH level. So increase PTH, have increase in calcium concentration. Next, here you have thiazide diuretics. The use of thiazide diuretics, it increases calcium reabsorption. So thiazide diuretic uh, increases calcium reabsorption. And then the next cause, you have prolonged immobilization or being bedridden. So it increases bone resorption. So bone resorption meaning you have transfer of calcium concentration from bone to blood. Okay, so those are the causes of hypercalcemia. So what are the symptoms of hypercalcemia? So first is neurologic, drowsiness, depression, lethargy, coma. And for gastrointestinal tract, you have constipation, nausea, vomiting, anorexia, peptic ulcer disease. And for renal, you have nephrolithiasis or the formation of kidney stones, and nephrocalcinosis or the deposition of calcium in the kidneys. So uh, it's also expected that if there is hypercalcemia, there's also hypercalciuria or increased concentration of calcium in the urine, and it can result to nephrogenic diabetes insipidus. So hypercalciuria is one of the causes of nephrogenic diabetes insipidus, meaning your body is producing enough ADH, but the cells in your kidneys is not that responsive to ADH, meaning ADH has no effect. So the body cannot retain water, cannot reabsorb water, so it will form urine. Okay, so polyuria. Okay, and that polyuria, so hypercalciuria causes polyuria, and that polyuria will result to hypovolemia. Okay, so there's a decrease in blood volume due to polyuria. Okay. So what are the treatment for hypercalcemia? So first is estrogen replacement therapy. Okay. So for estrogen replacement therapy, it's because um, menopausal women or estrogen replacement therapy for hypercalcemia is usually done um, in menopausal women because menopausal women are prone to hypoparathyroidism. Okay, so it's somewhat of a prevention for hyperparathyroidism. Okay, correction. Estrogen replacement therapy is usually done in patients that uh, um, estrogen replacement therapy is usually done in menopausal women because menopausal women are prone to hyperparathyroidism. Okay, so to avoid hyperparathyroidism in menopausal women, that's why we have estrogen replacement. Another is pyrothyroidectomy or the removal of uh, removal of the parathyroid hormone. Okay, so if the parathyroid gland has cancer or malignancy, and that's the cause of the excessive production of PTH, then you need to remove that parathyroid gland. Okay, so that's parathyroidectomy. Okay, so salt and water intake is encouraged to increase calcium excretion and avoid dehydration. Okay. Another, thiazide diuretics should be discontinued because regarding thiazide diuretics promote reabsorption of calcium. Another is biphosphonates because biphosphonates prevent bone resorption. Okay, so those are the treatment or possible ways to manage hypercalcemia. Okay. Next, determination of calcium. So the preferred specimen is serum or lithium heparinized plasma. So if you're using anticoagulant, use lithium. Okay, because if you're going to use ADTA oxalates and citrates, those are not acceptable anticoagulants because uh, EDA oxalates and citrates chelate calcium. Okay, so they remove calcium. So the effect is decrease in calcium concentration. So you have false decrease in calcium if you're going to use EDTA, oxalate, and citrate. Now, for the method, you can perform orthocresophthalin and arsenso dye 3. These are dye binding technique. And if you're performing orthocresophthalin complexone method, you're going to use 8-hydroxyquinoline. So this 8-hydroxyquinoline binds with magnesium in order to eliminate magnesium or to remove magnesium from the reaction. Okay, because magnesium can cause false elevation in your calcium concentration. So in order to avoid that one, that's why you add 8-hydroxyquinoline. But the reference method for calcium determination is still atomic absorption spectrophotometry. Okay, so I think that's all for calcium. Thank you and God bless.